Let's talk about radial scar or complex sclerosing lesion. One liner, it's a lobulocentric sclerosing lesion with a stellate architecture containing entrapped compressed glands that may mimic cancer. It has cystically dilated glands, often in the periphery, and stromal fibrosis slash elastosis, with radial scar often being smaller and more organized, and complex sclerosing lesions being larger and disorganized. This is benign, but it looks scary. Epidemiology, it's often 40 to 70-year-olds. It's less than 1% in screening mammography population and is frequently multiple in the same breast as well as bilateral. Etiology, unknown. And scar is a misnomer because there's no initial insult that leads to a reparative response. Here is a mammography of a radial scar slash complex sclerosing lesion showing right breast architectural distortion and some jagged slash stellate outlines. And this is a gross image of a resection that was done for radial scar. And we can see white fibrous tissue that is in an angulated stellate slash star-like figure in a background of adipose tissue. And you can imagine this looks clinically, radiographically, and grossly like cancer. But histologically, on low power, you see a stellate configuration that has peripherally dilated cystic glands, entrapped angulated glands toward the center, and they should have myoepithelial cells. It can be focal, but it will at least be there. Intermediate power, the stroma often has fibroelastosis. To me, it reminds me of solar elastosis that you can see in skin biopsies of elderly individuals. And on high power, the entrapped glands, as mentioned before, should have at least some myoepithelial cells. There can be associated proliferative lesions like usual ductal hyperplasia, adenosis, and sclerosing adenosis. Sometimes there can be associated atypical lesions like atypical ductal hyperplasia or ADH and atypical lobular hyperplasia ALH, up to 21 to 51% of cases. And there can also be associated DCIS, LCIS, or invasive carcinoma as well. That's to say, however, that complex sclerosing lesion and radial scar in and of itself is benign. It's just that you can get associated precancer or cancer lesions with it. So here is an H&E of a radial scar. We can see these kind of stellate outline, and we can see this fibroelastotic stroma with cystically dilated glands at the periphery of the lesion. And then the glands, the shapes themselves are entrapped, elongated. And so this is a radial scar. Here's another radial scar from a lower power view of another specimen. We can see this kind of sclerotic center with this fibroelastotic background with, and towards the periphery, some dilated glands. And then we can see some columnar cell change here with some secretions. And we can see the angulations of the glands. Here is an example of a complex sclerosing lesion. It's much larger. It's more disorganized where we can't really appreciate a single nidus. And you have that fibroelastotic stroma with cystically dilated glands, angulated glands as well, and some adenosis, some proliferative change. Oops. So this is another complex sclerosing lesion with some atypia here. And here's another view of this complex sclerosing lesion with DCIS. You can see a little bit of cookie cutter shapes, and the quality is not as great, so I apologize for that, but there's some monotony that we can appreciate here. And Due to the distortion of the glands and sclerotic stroma, it can be confusing whether the atypia is DCIS or invasive. So get your myoepithelial stains like your calponin and P63. Here's an instance of P63 highlighting the myoepithelial nuclei, confirming that this is DCIS and not invasive ductal carcinoma. This is an example of a radial scar with atypical ductal hyperplasia. So fibroelastic stroma again, some adenosis with some intraluminal calx, but here you see some slit-like architecture that has a pattern of cribiforming and with some monotony in the nuclei. This is a radial scar that's higher power with atypical lobular hyperplasia, where you can see some clearing out of the cytoplasm, some cellular discohesion, a little bit of expansion of the lobules in this background of fibroelastosis. And what you see here, although it looks scarier, it's less concerning than this ALH, is just apocrine metaplasia, which can have this endocrine atypia with enlarged nuclei, nucleoli, but the NC ratio, the nuclear cytoplasmic ratio, is the same. Here is a radial scar with invasive ductal carcinoma, and you can imagine that it's difficult to assess whether the entrapped glands are cancer or not. So when in doubt, get your myoepithelial stains. But here we see these single enlarged hyperchromatic nuclei cells that are not fibroblasts, which are more spindled, but single cells in the stroma, which is concerning for cancer. Here's another single cell in the stroma. And then we also have like nests of epithelial cells that are angulated without any lumens in the stroma too. So this is definitely concerning for cancer. And a myoepithelial stain is done here. A myosin stain is done, and you can see this gland doesn't have any myoepithelial cells. This gland here, some of these single cells and groups of cells don't have myoepithelial stains. It's confirming that this is invasive ductal carcinoma. I would say well differentiated. The treatment, it's debated. Some institutions, if there is no associated atypia on the biopsy and it shows radial scar or complex sclerosing lesion, they'll just observe the patient. But other institutions like myself, they will excise, as there may be a chance of unsampled lesion that may have atypia. And of course, if on biopsy it shows radial scar complex sclerosing lesion with atypia, you excise. The differential diagnosis is tubular carcinoma. It's also angulated and has a fibroelastotic desmoplastic stroma. Cytologically though, tubular carcinoma often has apical snouting, sometimes what you would see in like columnar cell change hyperplasia. The absence of proliferative findings and cystically dilated glands in the periphery can be a hint towards tubular carcinoma. Another hint is tubular carcinoma can infiltrate into breast adipose tissue, meaning it's non-lobulocentric. Another differential is low-grade adenosquamous carcinoma. This is a variant of metaplastic carcinoma, and you'll have irregular glands with regions of squamous differentiation. And it can be a differential diagnosis if there is radial scar with squamous metaplasia. However, low-grade adenosquamous carcinoma will be triple negative, ER/PR HER2, whereas radial scar should be ER heterogeneous positive. And here are my citations, and thank you. We'll see you on the next episode.